we have to say that we are nowadays in the field of lupus experiencing very interesting times. For the first time, we have in many countries already to approve biological therapies for lupus, in addition to several off-label biological therapies that we have been always using, but we have now two approved. And also there is a new anti-calcineurin inhibitor. And probably the most interesting thing is that even with the record of failure that we experienced in the recent years in the trials, we have several trials going on with great expectations. And one of these is deucravacitinib. It's probably one of the most complicated new therapies to pronounce, but it is here. It has just recently been approved by the FDA for psoriasis. And we have just seen recently the results of the phase 2 trial data in lupus. This is a tyrosine kinase 2 inhibitor that probably can fit into the treatment algorithm for patients with lupus. And we are just now waiting for the phase 3 trials to see if this is a new drug added to the list of innovative therapies in patients with lupus. When we think on the introduction of these innovative therapies for lupus, we probably always think on typical moderate to severe lupus patient that is already receiving, let's say, the standard of care, antimalarials, low-dose glucocorticoids, and immunosuppressive drug, and it is not adequately controlled. And then we always put the same question, which should be the next treatment. So probably before going to talk a little bit more on this new therapy, I would like to know which is your opinion. How do you proceed in such a patient? It moderate to severe lupus that is already on standard therapy and it is not adequately controlled. And this is an open question. You can give your opinions.
Well, in general, probably I will try to change the immunosuppressant or adding a belimumab or rituximab, depending of the organ involved.
I think that it would be also very important to see if there are differences in the way that we address this, depending on the part of the world. Manuel is coming from a Latin American country. I don't know if in the States, for instance, or in Canada, how do you proceed in these cases, Betty and Murray?
So we would do the same, and I don't feel that it's the right approach, but that's what we would do now, because our patients are already on one immunosuppressive. So either we increase the dose if it's a suboptimal dose of the immunosuppressive, or we change the immunosuppressive. And then now at least we have belimumab as a possibility. And for us, there may be voclosporin in the not too distant future. Let me just say off the top is that in all of the studies that have been done, where you add a new therapy into existing standard of care, which includes one immunosuppressive, the results show that the new therapy, 60% of people respond, as opposed to 40% or 30% in the placebo. So you're still only going to get 2 out of the 3 people that will respond, even when you add it. And that's why I made the plea that we've got to start these drugs earlier, not when the first drug has failed. So you're asking, what do I do? Right now, our hands are tied and we do sequential therapy. I'm hoping in the future, we'll be able to do earlier combined therapy.
Excellent. And probably this is certainly the way that we are proceeding nowadays, because this is also the way that the trials have been designed. But I think that there are unmet needs even in this situation. Probably this is the question that I would like to introduce now. Which are the current unmet needs at this moment that we are following this standard therapy? If it doesn't work, we start with new biological drugs, belimumab and ifrolumab, but which could be nowadays the unmet needs?
I guess going back to the question of where this new agent might fit into the treatment algorithm, it's not a drug that I have any experience using or any familiarity with, but I am excited by the prospect of having an oral treatment as a treatment option for our patients. And in addition to that, I guess we have to be a little bit cautious here in that we only have phase 2 trial data. We really need to wait for the phase 3 trial data before we can seriously consider where this agent might fit in. And the questions that I would have really relate to how efficacious it is ultimately in the phase 3 trials. And also its safety profile is always a consideration, and how much of a steroid-sparing effect it might have as add-on treatment to combination therapy, which a lot of our patients are already on, often including corticosteroids. So those would be my general thoughts, not really having a lot of experience with, or any experience with, this particular agent. And in Australia at present, in terms of targeted therapy, it's really the only agent that we have listed for reimbursed use in lupus is rituximab, so B-cell depleting treatment, which carries with it quite significant immunosuppression. And we've certainly had some of our patients who've had serious infective complications. So it would be nice to have a treatment that is less immunosuppressive, that's an oral treatment, and with good steroid-sparing effect and efficacy overall.
Thank you, Mandana, because this was certainly what I wanted to stress, is that if we still need something else to what we have currently, including ifrolumab and belimumab plus the off-label treatments. So I agree that these are very interesting things that probably we need: oral drugs, drugs that are safer, drugs that can be used earlier in the treatment of the patients. Murray, I think that you wanted to say something.
So, Ricardo, if I could add to what Manny said, which I agree with completely, is that the one thing about this study, it's the first study to mandate steroid reduction. In other words, there's a steroid reduction algorithm, which you have to do between weeks, I forgot, 8 to 20 or something like that, that you have to get down to 7.5 milligrams or you're considered a failure. And so this study actually accepts the concept that steroids are bad and we have to get them down. And I'm hoping all future studies will include some kind of mandated steroid reduction. And that'll hopefully differentiate the agent from the placebo effect. Because if you leave people on lots of drug, on lots of steroid, even the placebos will show some improvement. So I commend this study for that, and I hope that the phase 3 has the same kind of mandated steroid reduction program.
Waiting also for the phase 3 results, because also we have recent bad experience with another tyrosine kinase inhibitor with baricitinib, that in phase 2 the results were fine, but fail in phase 3. So let's wait for these phase 3 results, which are certainly very, very important. But apparently, what I wanted to stress is that probably it can add something to the current approach to patients with this moderate to severe lupus that I introduced you before. I wonder if any of you have already experienced on the use of these drugs or have participated in any of these phase 2 trials with lupus or in other autoimmune diseases?
No.
Mm-hmm. And which are probably your expectations in addition to what Murray said? I don't know. Betty, what is your opinion based on the mechanism of action? Apparently, this is slightly different than the baricitinib mechanism of action. So, do you expect better results?
You know, I've stopped making prognostications about how efficacious something is going to be. I think, you know, the side effects are not what we need our lupus patients to have: more rashes, acne, more disfiguring symptoms. On the other hand, getting rid of steroids is going to help with some of that as well. So that's, as well as lots of other things. So that's very important. You know, in the scenario you gave, I think the big question at this point is whether you would go to this drug or whether you'd go to belimumab. And I think at this point, everybody would go to belimumab because it seems to have quite a good safety profile. And while it's, you know, hardly a magic bullet, it has some efficacy. So it's, I think in this case that you've given, it's going to have to be as good as or better than belimumab. If somebody is already on belimumab, then that's a different story. And, you know, to what Murray was saying, I think one of the things we're going to have to figure out over the coming years is how to stop some therapies also. And so would you just add this on top when somebody is receiving belimumab, or would you think that you should switch? I don't think we have any idea about that yet. But we're not going to, somebody talked about healthcare access and access to medications. We're not going to be able to give patients in the United States, at least, you know, 5 different drugs that cost $30,000 a year. It's just not going to happen. So we know people won't take that kind of a therapeutic regimen. So we have to figure out when we substitute as opposed to when we add on. But we need a lot more information about this drug in lupus before we consider any of those issues.
For sure, but these are just expectations that we have. But one of the things that you introduce is the cost, and usually these small molecules, the cost is usually lower than with the biological therapies, and maybe probably this will link to 3 concepts that you have introduced in the previous comments. On one side, probably this could be easier to introduce in developing countries, probably. Maybe, Manuel, probably you believe that it would be easier to introduce this in Latin America, that much more expensive biological therapy. And Murray, maybe you can expect that probably this can be, we can start using this earlier in the treatment. It will not be necessary to wait until the failure of the standard therapy. We can start earlier because it will be probably cheaper.
You know, Ricard, what excites me about this discussion, I mean, so far everything is theoretical because it's still, we're just entering the phase 3 study. But what excites me is lupus has a multifactorial pathogenesis. And when I'm talking about combination therapy, I mean hitting multiple pathogenic mechanisms early. So this is This drug is anti-IL-12/23 inflammatory process and even decreases interferon, the type 1 interferon. And belimumab is an anti-B cell drug. So you're hitting the B cells, the 12/23 inflammatory mechanism, the interferon mechanism. If you're getting multiple mechanisms that way, and you do that early, your chance of putting it out are better, so you can start withdrawing medications earlier, as Betty suggested. So the fact that we're seeing multiple pathogenic mechanism new drugs excites me.
And I just probably will talk also on the risk that we have, probably also targeting different mechanisms. Also, probably we increase the possibilities of side effects.
Right.
What do you think?
But yeah, I think that's really possible. But hopefully, if you hit it early, you can withdraw more quickly. Mm-hmm. You know, in other words, hit it from multiple points, and then you don't. If the fire is on and you're hitting multiple hoses and put it out, you'll be able to stop the hoses earlier. I mean, this is all theoretical, but the fact that we're having this opportunity now because of multiple new pathogenic mechanisms, the drugs with new anti-pathogenic mechanisms, it's a very exciting time. I wish I were 30 years old.
Well, I think one of the other issues, since Murray is raising this kind of consideration, is that no, we believe there may be people who, have a disease more driven by autoantibodies, others more driven by myeloid cells, and we may start to find what we all believe, which is that one size does not fit all. So if we do our studies in a sophisticated way, we may be able to identify those who are going to respond better to this drug than, say, belimumab, those who might need both, and those who would do better on belimumab than this. So, I think that these studies are not going to necessarily be done by drug companies because they don't want a smaller patient pool. So they just want to get registration. On the other hand, then it's going to be on us to do those kinds of more targeted analyses.
There's your next 25 years, Betty. Get them for us.
I'm staying around, Murray.
Okay, yeah, me too. But
I'm not leaving.
You think, we thought we had it, with the anti-interferon with anifrolumab, but in terms of the anifrolumab responders, 80% had a high interferon level and or signature, and 20% didn't and still responded. So we have to really get much better even at So there's a lot more work to be done in the science labs to help us pick the right biomarkers for each patient.
Sure, and hopefully we will not need to wait for 25 years to have the answer to all these questions, and quite soon we will have some additional information, pieces of information to better treat our lupus patients. So thank you very much, really, for addressing this new drug and the expectations that we have with this drug.